This page shows consensus treatment goals for CKD. We want to decrease serum phosphorus. We would like to lower dietary phosphate intake in our patients, bind dietary phosphate using phosphate binders. We also want to decrease parathyroid hormone. We would use vitamin D analog as a first-line agent or give calcium mimetic agents. We would like to maintain serum calcium concentrations, give active vitamin D for severe progressive hyperparathyroidism, consider calcium-based phosphate binder if symptoms of hypocalcemia are present. We would like to avoid soft tissue calcification and renal osteodystrophy. So in the picture of this x-ray, you can see the patient's hand, and I have made a yellow square to indicate the soft tissue calcification. Many nephrologists base management on KDIGO guidelines. CKD MVD KDIGO guideline was updated in 2017. What it stated is that for phosphorus stage 3 to 5D, D standing for dialysis, their goal is towards the normal range. Calcium for stage 3 to 5D, they said the goal would be avoiding hypercalcemia. One thing that we need to remember to do is correcting the calcium according to the serum albumin. Patients may have lower than 4 or higher than 4 serum albumin. When the patient has less than 4 of serum albumin, your calcium tends to be underestimated. So we are adding the current serum albumin plus 80% of the difference of serum albumin from 4. This equation is a must-know for the exam. Parathyroid hormone for patients on dialysis, it tends to be 2 to 9 times upper limit of normal. Normal range is 10 to 60. For the exam, CKD 3 to 5, not on dialysis, I would use PTH level for normal range, which is 10 to 60. For patients who are on dialysis, we would use this number 2 to 9 times upper limit of normal of 10 to 60. It comes out to be about 550. In terms of monitoring calcium and phosphorus, the guidelines suggest for CKD3 patients, you would monitor calcium and phosphorus every 6 to 12 months for PTH based on baseline level and CKD progression. For CKD4 patients, they suggested to measure calcium and phosphorus every 3 to 6 months, PTH every 6 to 12 months. In CKD5 patients, they recommended monitoring calcium and phosphorus every 1 to 3 months, PTH every 3 to 6 months. Approach to monitoring may vary from facility to facility. So our hemodialysis clinic measures calcium and phosphorus every month, and they measure PTH every 3 months. Should you be concerned with vitamin D? Calcidiol levels might be measured and repeated testing determined by baseline values and therapeutic interventions. When to measure levels, how often to measure, and what levels to target should be individualized. In general, for phosphate binders, it binds the phosphorus in the GI tract. They form insoluble and non-absorbable complex. It must be taken with meals to be effective. So if the patient is taking phosphate binders after the food, it's too late. There are several types of phosphate binders, as you know. First two are calcium-based binders. Second two are non-calcium based, and last two are iron-based binders. And lastly, there's aluminum or magnesium-based binders, which we don't often use. There are two commonly used calcium-based binders that are available, which is calcium acetate and calcium carbonate. The pros and cons for the calcium-based phosphate binders are on this table. In all phosphate binders, GI side effects are very, very common, and especially for calcium-based binder, one of the cons is increased risk for hypercalcemia, which also can lead to vascular calcification as well. These are the dosing for both drugs. Some of drug-drug interactions are listed for calcium-based binders. Fluoroquinolones and tetracyclines bind to calcium to decrease efficacy of the antibiotic. So we need to space the antibiotics with phosphate binder. And absorption of oral iron is decreased when you take it with calcium as well. So you need to separate those doses. As you can see, in terms of elemental calcium, calcium carbonate has more elemental calcium. So depending on your patient, if the patient is having hypocalcemia, you would probably choose calcium carbonate. Whereas if the patient has insurance problem and has borderline hypercalcemia, you would probably choose calcium acetate over calcium carbonate or sevelamer, which is more expensive option. Sevelamer is non-absorbed polymer-based binders. The pros and cons for sevelamer are listed on the table. Phosphorinol or lanthanum, it is also used as phosphate binder. Pros and cons are listed on the chart. It is a chewable tablet, however, it's very, very difficult to chew on. So patients with denture problems may not be able to use lanthanum as much as you could. Sucroferric oxyhydroxide, the brand name is Velphoro. It's iron-based binder. Side effect, again, GI and also dark stool. It is non-absorbable iron-based binder. It is expensive because it's pretty new in the market. It is also chewable tablet. However, this is more softer or easy to chew on compared to phosphorinol. Ferric citrate is another iron-based binder, brand name Auryxia. It also has side effect of GI problems and dark stools. This one is absorbable iron. So there are many studies with ferric citrate in terms of decrease in IV iron and ESA uses, because if you use ferric citrate as a phosphate binder, it increases the TSAT and ferritin and hemoglobin levels. However, again, this is more expensive because it's new in the market and it does have maximum daily dose. So because it has absorbable iron, they do have maximum daily dose compared to the previous iron-based binder. Aluminum hydroxide and magnesium hydroxide, these are effective at binding phosphate. However, it's only used as a short term. Aluminum and magnesium accumulate in patients with renal dysfunction. Aluminum can cause CNS toxicity, constipation, bone problems, anemia, whereas magnesium can cause respiratory depression, CNS toxicity, hyperkalemia, and diarrhea. This is a summary table for phosphate binders.